Okay, so welcome on behalf of Therapy Ed. Tonight's topic will be on physical agent modalities and therapeutic exercises. And my name is Kali Mar, and I'll be your instructor for the evening. So the first, I'm going to start with physical agent modalities, and I'm going to start with superficial thermal modalities. And the ones that fall under that category that are most commonly used in occupational therapy are your hot packs, your paraffin, your flutotherapy, and whirlpool. Okay. And just so you know that sometimes in some of the textbooks, and I notice on NBCOT's website that they had indicated that flutotherapy is sometimes referred to as a dry whirlpool. So just you may see it termed that way on the exam. So why do we use superficial thermal modalities? One is to increase tissue extensibility. So when I think of heat modalities, the number one reason as a therapist for many, many years that I would use heat modalities is to increase tissue extensibility. I want to stretch those tissues, those musculotendinous units. I want to stretch those out. We also use heat modalities to help with decreasing pain and for muscle spasms. Those are the main reasons that we use it. Now, when you are studying for the exam, you need to go through each one of these and make sure you have a general idea of how to apply it. But most importantly, why would you select one over the other? Okay. Know your superficial thermomodalities, but know why one over the other. And of course, know the things that I have listed here, the contraindications, the precautions, safety concerns. And just think about your clinical reasoning as you are selecting the right physical agent modality. So again, when I think of superficial thermal, I'm thinking heat modalities, and I'm thinking I definitely would use that for somebody who has a tight shoulder or a tight elbow joint. I'm going to take and I'm going to put heat on that joint to try and increase the tissue extensibility. Now, contraindications. Why might I not use a heat modality? Post-surgical patients. So right after surgery, we are not going to be putting a hot pack on a person's surgical site. We don't do that. Okay. So it's going to be a little while before the doctor will okay us to be able to use heat with that patient. So right after surgery, we do not use it. For acute injuries and infections, it's contraindicated. You also need to know that if a person has impaired or absent sensation, we never use heat modalities. Okay, so we don't use them. You may see it often, not often, but you may see it out there in practice with more experienced therapists using it. But just so you know, for the exam and what is in your textbooks is that it says that heat modalities are if a person has impaired or absent sensation, heat modalities are a contraindication. Also, if you get a scenario on the exam with somebody who has rheumatoid arthritis and they describe them as having an acute flare-up, usually where the joints are swollen, hot, and red, we're not going to use a heat modality. So that would be a contraindication. Somebody who has impaired circulation or edema, not going to use any kind of heat modalities. Active cancer and tumors. MS, you must know that for the exam, that if you get a scenario with somebody who has MS, using extreme heat, like a hot pack or something like that, is considered a contraindication. It could cause a temporary exacerbation of their symptoms, so we don't use it. DVTs and lymphedema. Those are your other contraindications. So just make sure when you're studying, you're reviewing not only why would I use heat, but what are the contraindications? What do I need to be concerned with? And in the scenario that they give you, are there any of those contraindications that would make you say, oh, I'm not going to use a heat modality? Precautions. These are just precautions, things you need to be, careful when you are using physical agent modalities of any type with somebody who has fragile skin. As we get older, our skin becomes, thinner and more fragile. And so we do not want to put heat or any kind of extreme heat over it. Or sometimes if we decide we need to, because they do have tightness in their joints and we want to increase that extensibility, then what we may do is use extra toweling between the person's skin and the hot pack or whatever modality you're using. Also, children, you have to be cautious when you're using any kind of heat modality on a child. Are they going to be able to verbalize and tell you that this feels too hot? So you have to be very attentive if you decide that you are going to use it. And then for somebody cognitively impaired, are they going to be able to tell you again, does this feel hot? Is this too hot? So we have to be especially careful, especially cautious with those three things. And, I like using physical agent modalities, but it's not what makes the big difference is the exercise and the activity and the occupations that you do that follow it up. And so that is going to be extremely important for you to, keep that in mind. Always err on the side of safety. Safety is so important. And so, yes. Now, so coming up to the next thing is safety. You want to make sure that anytime you want to give a patient a physical agent modality, that you have a prescription for it. So on the exam, they may ask, what is needed in order to provide this person the following interventions? Well, one thing is you have to have a prescription that says, okay, use hot packs, use whirlpool, electrical stimulation, whatever it is. The other thing from a safety standpoint is you always, no matter what modality you are using, that you always do skin checks. You want to do skin checks before, during if possible, because like when we do paraffin, it's not possible. So we have to do it before and we do it right after. But when we can do skin checks, we want to. So about 5 minutes into the session, you should be checking their skin. Like if I'm using a hot pack or I have the person in like a whirlpool, I'm going to have them bring their hand up so I can see, is there any concerns with this person's skin when I'm doing the different modality that I'm doing. Um, and then also too, temperature checks of the modality. Now, a lot of your physical agent modalities have built-in thermometers, but you should, as a second check, always have another thermometer there. So it's very common to go into an OT department and see a paraffin machine that has a built-in thermometer with another thermometer nearby that you can put in to just double check to make sure the temperature is where it should be. Okay, the same thing with the hydrocolators that you keep the hot packs in. You want to take and make sure you have a thermometer in there, even though it might have a built-in one, have an extra one. It's an extra safety check. And then when you are thinking about you want to use a heat modality, some things that you're going to want to consider in the scenario that you want to consider what is the diagnosis that they're describing in the scenario, okay? So are they describing somebody who has let's say a flexion contracture of the PIP joint of the index finger, or are they talking about somebody who has stiffness of their shoulder? Those are two completely different, structures. And so you need to think about what would be the best modality. Okay. So, obviously I'm not going to do whirlpool on my shoulder, or I'm not going to do paraffin. And probably the best heat modality for me to use on the shoulder would be a hot pack. Okay. But then when I get down to the PIP joint, I have more of a choice. Okay. Almost any of those that are listed up there would work, but you have to see which one would be best. And you have to also consider too, like, the person and how, they're able to share how they feel with the modality and stuff. Do you want to put them in a physical agent modality that you're going to be able to check their skin, midpoint during the modality? So that's going to be important for you to do. Just 1 second. There we go. Um, and then also equipment that's available. You might get a scenario on the exam and it's a home care therapist. Okay. So you're not going to have a flutotherapy. You're most likely not going to have Whirlpool. You may have paraffin. People can buy paraffin machines now. You might have your own hot pack that you bring. You want to look at the actual kind of setting that they describe in the scenario and what equipment might be available. You also want to consider the patient's tolerance. If anywhere in that scenario it says the person feels uncomfortable with the hot pack or with the paraffin, stop it. Don't that would be my response is to stop the modality, okay? Because again, it's only a preparatory. It's only help to get the tissues ready for what we're going to follow up with. Okay. And the other thing that you would consider too is that almost all of these modalities that are listed up here have research that backs them up. Okay, they have research that backs them up. And one thing that I do want to say is your regular Whirlpool, okay, is commonly used for cleaning wounds, debriding wounds, wounds that are dirty, okay? It's not used that much as a heat modality because of the temperature of the water. It can't get the tissue up to a therapeutic range. So regular Whirlpool is not used that much as a heat modality. It's listed there because it's in your textbooks, but it's not that common. And that's why now they have the flutotherapy, which is a dry Whirlpool and can get your tissues up to a therapeutic range, which is what you want so that you can get that extra extensibility. And then the most important thing is you need to think about what am I going to do to follow up with this physical agent modality? So, what kind of purposeful or occupation-based activity? The next physical agent modality are your superficial cooling agents, or we refer to them as cryotherapy. So you'll see that in there. Cold packs, you might see cryotherapy. The two that I have listed here are your cold packs and your ice massage. Okay, they're the two most commonly done out there in occupational therapy. So let's talk about the indications. Um, Relieves pain. When I think of cold packs, okay, I think definitely, without a doubt, pain is so important. So if you get a scenario and it says the person has, significant pain, you want to definitely think, oh, the modality I would probably choose would be an ice pack, unless they have one of the contraindications listed there. We also use cold packs for decreasing edema. And one thing that I want to say, very important, is if you're going to use a cold pack to decrease edema, let's say the hand has edema throughout. Maybe they had a Colles fracture and they have swelling throughout. If you're going to use a cold pack, whatever you do, don't take that hand and place it on a table flat. You need to make sure that your hand is elevated above your heart. Then put the cold pack over top of it. And then afterwards, followed up with massage and exercise. All of those things help to feed into decreasing edema, but always should be combined with just not the cold pack flat on a table. You want a cold pack and elevation. That's ideal situation. Then follow that up with the massage, then the exercise and the activity to continue to pump those fluids out. Also, your superficial cooling agents or cryotherapy is used to decrease abnormal tone. So, in some of your patients, you may, feel abnormal tone. So, we use cryotherapy. But interestingly, too, we also use cryotherapy to facilitate muscle tone. So, you need to think about your scenario. What are they saying? What are they asking for? And what would you use it for? It's common to use ice after post-surgical repairs in acute injuries. So you guys know somebody falls and they sprain their ankle and it's swollen. What do? We put ice on it. We elevate and ice. That's for any acute injury, okay? Elevate and ice, very important. Elevate above the heart. Post-surgical repairs. Many times, like I would see patients after a rotator cuff repair. They just had surgery, would go up into their room. And way back when, we used to start them a lot earlier than what they're starting them now. But whenever we went up there, they had already given them an ice pack. So they already had an ice pack. So a lot of times your inpatients have an ice pack already on them. So it's not uncommon for after a surgery for them to be given an ice pack. Again, anytime you use a physical agent modality, you want to make sure that you have a prescription for it. Contraindications, very similar to the heat ones, sensory deficits, so impaired or absent sensation. Okay, not going to use it. For somebody who has so that's impaired or absent sensation, impaired circulation. I'm not going to use a cold pack, and I wouldn't use it on somebody who has peripheral vascular disease. So any kind of vascular problems, um, thrombophlebitis, DVTs, or Raynaud's disease. So those are a definite contraindications of why you would not use cryotherapy. So no matter what the situation is, if they have any of those listed in the scenario, in the question on the exam, you want to know that you're not going to select it if they have one of these contraindications, because there's other things that you can select. You have to use your clinical reasoning and come up with other ways that you can address that person's issues. The precautions are the same that I mentioned before. Fragile skin. You're not going to want to put ice on somebody who has fragile skin, or a child, or somebody who's cognitively impaired. They may not be able to tell you what they're sensing. Um, Safety, again, you need the doctor's prescription. You need to do skin checks before, during, after. So when you're using an ice pack, that's easy to do. Now, it's not uncommon for you to, do ice massage and the area become a little red, okay? Now, when we do ice massage, so ice packs, everybody knows what the ice packs are. They're usually gel. They're usually kept in some kind of a freezer or hydroculator that's cold, or some kind of refrigeration. And then there is the ice massage. These are like little ice pops, like little popsicles. Often we take a styrofoam cup, we put a tongue depressor in there, and we freeze them, like make little popsicles. And ice massage is excellent for somebody who has localized pain. So if I have a Colles fracture and I have pain throughout my wrist and hand, I'm going to use a cold pack. Okay. But if I have lateral epicondylitis and I'm saying my pain is right there, I'm going to use ice massage because it's very localized. Or if I have Decker veins and the pain is specific to this area. Now, it doesn't mean I can't use a cold pack, but your ice massage may be much more effective. So you have to think about, why would I use one over the other? The other thing is, how do they manage this at home? Well, a lot of people have frozen vegetables at home in the freezer. They can use that as an ice pack at home. And a lot of times, do you use a dry towel or a wet towel? You want to put something in between the person's skin and the cold pack. And so you can put a dry towel, but it's going to take a little longer for it to penetrate, versus a wet towel, like a wet paper towel. Sometimes I'll take and place the ice pack right on the wet paper towel between your skin. And it penetrates a lot quicker, but you have to be cautious. Okay. Now, again, your clinical reasoning for, why choose a cold pack or ice massage. Consider the diagnosis. Again, I just gave you an example. If somebody has a rotator cuff repair, I'm going to use a nice pack, a cold pack, okay? Or if they have Colles fracture and they've got a lot of pain and swelling, I'm going to elevate their hand and I'm going to use a cold pack, putting it on the dorsum of the hand and wrist. But if they have Decker veins and their pain is very specific to the area where the Decker veins occurs, I'm going to do ice massage, okay? If they have lateral epicondylitis, I'm going to do ice massage to that area. And sometimes even with like lateral epicondylitis, which is tennis elbow, it can radiate down into the arm. But often the source of the problem is at the lateral epicondyle. So we often will do the ice massage there. And when we do ice massage, we just do it for a couple minutes. They say in the book, I think up to 4 minutes, 4 to 5 minutes in circles. But honestly, I might do it like for 2 minutes and then I do some massage, then I do it for 2 more minutes, and then I do some massage because it can become a little uncomfortable. But at one point, it starts to actually become numbing. But you want to be careful because you can burn a person as easy from a cold pack as you can from a hot pack. And so that's one of the big things about using physical agent modalities is it's a riskier treatment that we do. They're at risk for, burns and other kinds of problems. Um, so so yeah, so you want to think about that. Equipment available, honestly, if you're in a person's home, most people have frozen vegetables. And if you're a home care therapist, you can make one of those little popsicle things so that the next time you come, you can do the ice massage. And again, also the patient's tolerance. Cold is much more difficult for a person to tolerate than heat, especially with the ice massage. However, after surgery, okay, or if a person has a lot of pain, they like the ice, okay? You want to look at evidence, and there's evidence that backs up the use of ice for addressing pain and edema. And again, as OTs, we never select a physical agent modality without following it up with a purposeful or occupation-based activity or both. The next physical agent modalities are electrical stimulation. And so I have the most common ones that are used in OT. There are some others, but these are the most common ones. So we have the TENS, the NMES, the FES, and the iontophoresis. These are all they're listed in our textbook, but they're also in your regular PhysDis textbooks. You can, open them up, and if you want to read more about those, you can. But when I think of these modalities, we use them for different reasons. Pain, TENS is really big for pain control. Iontophoresis is using electrical stimulation to drive medication. So it's non-invasive. It's not like they're injecting it into the skin, but they're using electrodes and putting the medication under the electrodes to drive the medication to the area where the person is having pain. We use electrical modalities to help with decreasing swelling, but we especially use it for muscle re-education and strengthening muscles, and also to stimulate denervated muscles in which the nerve is not activating the muscle at the time. So, so when I think of NMES and FES, they're sort of the same. Neuromuscular electrical stimulation, NMES, that is going to be used to re-educate and to strengthen your muscles. And we use FES, functional electrical stimulation, which is very, very similar, but we use it also in conjunction often with activity. Okay, we use TENS if a person has a lot of pain, like I was involved in doing work programs with patients, and a lot of the patients had low back pain. And so often what we would do is we would set them up on a TENS unit, putting the electrodes in the lower back area, and they could then control the TENS unit so that they could then perform the different work activities that we were asking them to do. So we use these in conjunction with activities. Now, the contraindications, these are key and very, very important for you guys to go through and review. So when I think of electrical stimulation, no cardiac pacemakers, phrenic or urinary stimulators, or any implanted electrical stimulation. Just remember that. Also, other contraindications include thrombosis, thrombophlebitis, over your carotid sinus. We're not going to do it over metal hardware. And there are other general contraindications that you need to go and take a look. We have some, I think, at the end of this and definitely in our book. Precautions are the same. People have difficulty tolerating the electrical stim. So one is their skin fragile? Are they going to get irritated from it? Children and people who are cognitively impaired, are they going to be able to tell you, oh, that's enough. That's enough stimulation? They may not be. So I don't know if that would be my first choice. If they gave you, select the best physical agent modality and the person has a cognitive impairment, I would really be concerned about using it with them unless it was a mild cognitive impairment, because I would want to make sure that they would be able to understand, what they were experiencing. Um, Safety, again, make sure you need to have a prescription. Absolutely. You're going to do skin checks before and after, and you have to be careful because there are some, electrical stimulations where you can get a burn under the electrode. Like sometimes I've heard of it with iontophoresis or iontophoresis. So just be cautious with it. They've improved these machines and the protocols and stuff, but it's something that you just want to be careful of. And so for the exam, I don't think you have to go into great detail with the parameters, the protocols, and the dosages, but just have general understanding. Go through your books and look at, the different scenarios that they might give you. And then for your clinical reasoning for electrical stim, again, consider the diagnosis, the structure that's involved. Um, Obviously, I'm not going to put electrical stimulation on somebody who just had a rotator cuff repair. Okay. They just had it repaired. I don't want to rupture the repair. So I'm going to be very careful. But have I used neuromuscular electrical stimulation for somebody who has a radial nerve palsy as they started to get return? Yeah, I would take and set it up on the extensors to try to help, encourage more wrist and finger extension. So you need to think about the diagnosis and the structures involved, and also the available equipment. If this is somebody you're going to use it in your department, that's okay. But if they're going to go home with like a TENS unit, you need to figure that out. Like you need, are you going to have a vendor come in? Who's going to cover it financially? Is the insurance going to cover it? These are all things that you have to keep in mind when you're considering that, even as out there in practice, but on the exam, they might give you an example of something like that. So, again, always try to follow it up with some type of purposeful or occupation-based activity. And in the case of TENS, it's not uncommon for us to use TENS during purposeful and occupation-based activities. It's rather common. The next physical agent modality is ultrasound. And there's two types that you need to be aware of and go back and review a little bit. There's continuous, which is your thermal ultrasound, and there's pulsed, which is non-thermal. Okay. And so when you think about continuous, it's thermal. So think about your heat. What does it do? It increases extensibility. It also can help in reducing pain, increasing blood flow, and reducing muscle spasms. So very similar to our superficial heat modalities. Here's the big difference with your continuous ultrasound from your other superficial heat modalities. It can reach a depth of 4 to 5 centimeters. That's one of the key things about continuous the thermal effects of ultrasound is it can reach a depth of 4 to 5 centimeters. So like when a person has a frozen shoulder, okay, that's your joint capsule and your ligaments, which are deep to your deltoid, deep to your rotator cuff muscles. And so they are deep. Okay, so we need to think about what modality would be most effective. So ideal, because it's all, you have to figure out what part of the joint capsule, but ideal is if they're having a hard time raising their arm up over their head, I'm going to use ultrasound in the inferior joint capsule, trying to heat that up because it's going to go deeper than what a hot pack would. That doesn't mean I wouldn't use a hot pack, because sometimes I'll put a hot pack on and then I'll follow it up with 5 minutes of ultrasound in the inferior joint capsule if they're having a problem raising their arm up over their head. So that's one of the big differences. So yes, it increases extensibility, can help with reducing pain, muscle spasms, But what makes it different from the superficial heat modalities, it penetrates 4 to 5 centimeters. Pulsed ultrasound, so you can use it for non-thermal effects where there's no heat, is used to help decrease inflammation and also for tissue healing and for scar tissue. Therapists will use it. Now, these are big. These are some contraindications because ultrasound is using sound waves, okay? And so you have to be careful, like things like growth plates and fractures, okay? You do not want to do it ever over a growth plate and not over a newly fractured bone. Infections, inflammation, pregnancy, some joint replacements, but I just say, hey, if the person has a joint replacement and you see that on the exam, don't use ultrasound. Don't select that one. Thrombophlebitis, active cancer, hemorrhagic regions over your spinal cord. You're not going to use it over your spinal cord. And not using ultrasound over metal hardware or any bony prominences, especially the continuous, because you could burn somebody because your bone is so, remember, it goes so deep. So you don't want to burn somebody. And avoid near any pacemakers or breast implants. Now, precautions are the same as all the others. And I added one other thing that I just want to bring to your attention is soft tissue repair. So like somebody has a flexor tendon repair. We're not going to do ultrasound right away. Now, some therapists are a little aggressive and they do it, but be cautious, always for this exam, especially until you become more experienced. Always err on the side of safety. And so in your textbook, some will say, be careful with soft tissue after soft tissue repair. And because you don't want to rupture the repair. Again, it's using sound waves that can disrupt that repair. Same thing, check MD's prescription, make sure that it's ordering ultrasound. You're going to do skin checks and just become familiar with your parameters, your protocols, and your dosages. And what I like about our OT PhysDis textbooks, if you look under physical agent modalities, they do a really nice job describing each one of these modalities and talking about in very simple terms, understanding, the parameters in the dosage. So go over that. Again, with all the other physical agent modalities, consider the diagnosis, the structures involved, especially the depth. Okay. So again, I'm going to be very cautious on using continuous when it's at my PIP joint and how much I'm going to use. So you have to watch your parameters, your dosage and everything. You have to, usually patients, unless it's overheating the structures, it's very uncommon for a person to have difficulty tolerating the ultrasound. There is definitely evidence that backs up the use of ultrasound. Now, you may have also heard phonophoresis. You'll see that when you read about ultrasound in the book. Phonophoresis uses the ultrasound to drive medication into wherever the person's having pain. So it's non-invasive. You're not injecting anything, but under the ultrasound head, they put medication and it drives it into that area. That's called phonophoresis. The thing is, the research on it has been a little bit inconsistent. So if you were to be asked a question on the exam about which modality would be best to help with, delivering medication to a painful area, I would select iontophoresis, which has a better research, more consistent research than phonophoresis. Okay. So these are just some general safety tips for using PAMs. PAMs should not be used in isolation. A while, back many, many years, I used to get orders from doctors to, treat a person for paraffin treatments for their hand. They had rheumatoid arthritis. And yes, it feels great, but you cannot just have a person come in and treat them for paraffin. Okay. Now you can have them come in and educate them on the use of paraffin. You have them come in for maybe 1 or 2 sessions and you educate them on the use of it. But unless they're going to be in there for therapy, if they have other needs, then you would use it along with addressing their occupations. You must make sure as new therapists, and on the exam, you might get something like this, and they'll put like entry level OT, okay? Um, you must establish competency for using PAMs as an OT intervention. You should also be aware of your State Practice Act, but this is a national exam, so they're not going to ask specific state, Practice Act questions. But you need to know that you do need to establish competency, that just having, a class or two in school that goes over PAMs does not make you competent. So you set up a way to become competent, find a mentor, attend a competency course where, you have to take a test at the end. Do what you can to make sure you feel comfortable. And, like I said, some states offer these certification courses too for you to become certified in it. Know your indications, your precautions, your contraindications, and that they must be strictly followed. And so once in a while, when you're out there practicing, you might see a therapist, stray a little bit from the contraindications. But you're taking this exam, and they're going to want to make sure that you know what the literature is saying as far as contraindications. And you want to be very strict with that and follow it. General contraindications are listed here, and we have them listed in our book. Things like active cancer, vascular issues, sensory issues, infections, cognitive impairments. And prior to using PAMs, check your text and literature for additional contraindications and precautions. Things are changing all the time. Protocols are changing all the time. So just make sure that you keep checking those. Okay, now I'm going to talk a little bit now about therapeutic exercise. This is used prior to engagement in purposeful and occupation-based activities. So we just talked about physical agent modalities. Probably following a physical agent modality, the next thing you might do is a therapeutic exercise. You must adhere strictly to the MD's prescription. You must know your contraindications and precautions. Like a post-surgical patient, are you allowed to do active range of motion, or is it strictly passive range of motion? Somebody who has an acute injury, infections, are you allowed to do exercise with them? Fractures, is it too early to begin moving them? So you need to be aware of any precautions or contraindications. And, when I think about a main contraindication, like when I think of strengthening, I think about isometric strengthening for somebody who has an active cardiac history. Okay, isometric exercises are contraindicated. You need to know that going into the exam. So, what are the indications? Well, to increase active assist, passive range of motion, and to increase strength and endurance. That's why we do therapeutic exercises. So it's very biomechanical, okay, but never used in isolation. We would not just use a physical agent modality and therapeutic exercise without following it up with a purposeful activity or an occupation-based activity or both. Know the difference between range of motion and why one over the other. You need to know that. These are the basics of exercise. So you know that active range of motion, if you get an order for active range of motion, that means the person is using their own muscle strength to produce the movement, okay? They're using their own muscle strength. That means hands off. If the doctor orders active range of motion, that means they don't want you assisting that person, because once you do, that's active assist range of motion. The doctor is ordering active range of motion. And a common diagnosis that we do active range of motion with is somebody who had a fracture, like a Colles fracture. They come out of their cast. The first therapeutic exercise we most commonly give is active range of motion, unless otherwise stated on the doctor's orders. Okay, so you have to see what the scenario says on the exam, but very common is active range of motion. And that means you do not assist them at all. You can demonstrate it, you can support them, but they need to do all the movements themselves. Okay, and so using their own muscle strength. And in the hand, there's things like tendon gliding exercises that we do. You should be familiar with those. blocking exercises if it's a specific joint. So they might ask you about, a certain finger injury and what would be the best exercise. When I think of tendon gliding, I think of anything that involves the tendons that helps them glide through their tendon sheaths. When I think of blocking exercises, I think of those as specific to the joints and the hand, that you can block and isolate each of those. And there's nothing like doing functional activities to help improve active range of motion. Now, active assist range of motion is performing using your own muscle strength and the assistance of an external force. That external force might be, a therapist assisting them as they're doing their exercises, or using a cane. If it's your right arm this week, you're using your left arm to assist that right arm up over your head. That's active assist range of motion. Passive range of motion is performed by an external force, okay? The muscles are not contracting. Now, we do passive range of motion for usually two main reasons. One is post-surgical. The doctor did a surgery and they only want passive range of motion. We see that a lot with a lot of the shoulder surgeries, okay? You get a diagnosis on the exam and it's a rotator cuff repair, it's a shoulder fracture. It's not uncommon for us to always be given an order of passive range of motion. Sometimes a doctor will say active assist, but commonly it's passive range of motion. And that is, they do not want their muscles, the patient's muscles contracting. So you have to make sure that the patient understands when you start to move them, they are not to help you, that it's pure passive range of motion performed by an external force. Now, sometimes we do passive range of motion because somebody has a flaccid extremity, and so we help to passively move it because they can't actively contract their muscles. So when we do passive range of motion, it's an external force, which can be the therapist. It can be a CPM machine, which stands for continuous passive motion machine. It could be the patient using their other extremity, such as in self range of motion, where they passively move their arm. And when you do passive range of motion, and this is a key thing I want you to all remember, super important. Passive range of motion is moving the body part to end range. So what is end range? So I take it, I move my arm up, and I get to this point. End range is where I feel resistance, or the person says, oh, I got pain, stop. That's your end range. That's passive range of motion. So when you do passive range of motion, it's moving that person to their end range or to where they feel pain and they want you to stop. Passive stretching is very different from passive range of motion. Do not confuse them on the exam and do not confuse them out in practice, or you can end up having a lot of issues. Passive stretching is also performed by an external force. It can be the therapist or the person using their other arm. They're taking it to their end range. Again, that's where you feel the resistance or the person has pain. But then they're going to take and apply overpressure. Okay, so it's much more aggressive. It's much more aggressive. So passive stretching is you're doing passive range of motion to their end range, and then you're applying overpressure. So be careful on the exam how they say, if they describe something, is this passive range of motion? Is this passive stretching? And one thing that I want to say is that when you document what you're doing with your patient, if the doctor ordered passive range of motion for your patient, whatever you do, don't go out there and document that you did passive stretching when you did passive range of motion, but now you're documenting that you did passive stretching. It's very common for therapists to use those terms interchangeably, but can get you into a lot of trouble if something happens to that person's shoulder or extremity, whatever body part you're dealing with. So passive range of motion is just taking the person to their end range. Passive stretching is end range and overpressure, so more aggressive. We see that in people who have, like more of they're starting into the thawing phase of a frozen shoulder. They're coming out of it a little bit, so we can be a little more aggressive. But you're not going to see that with your post-surgical shoulder patients, okay? Not for a couple weeks. The doctor will let you know when it's okay to continue. Strengthening, do not proceed to strengthening until approved by the MD. You be very careful on the exam how they write the scenario. We never, no matter how well the patient, if you see a scenario where it says the patient has been referred to occupational therapy for pain management and active range of motion, and then they say, but the patient is now feeling better and feels like they can progress, how would you proceed? You're not going to pick the answer that says strengthening unless it says that the doctor's order includes strengthening. So we never, no matter how great the person feels, you've got to get the doctor to write the order to progress to strengthening. When we think of strengthening, that's using high resistance and low reps. So we're not doing a lot of reps. If we were doing a lot of reps, we would be working on endurance. Also for the exam, know your contractions. Know isometric, which is a muscle contraction without movement. Again, this is a contraindication for this is cardiac history, but isometric exercises are very common, especially in the shoulder after surgery when they have gone through their different range of motions and they're ready to begin strengthening. It's not uncommon for a doctor to order isometric. Sometimes you'll hear it called submaximal isometric, meaning you're not going full force, just slowly starting to have them contract, but without movement. Concentric, eccentric, and isotonic. When I think of isotonic, that is a contraction, but with movement, okay? And the doctor is not concerned with any kind of length, like if the muscle shortened or lengthened, you can go ahead and pretty much do anything. That's your TheraBand exercises. That's your free weights. So isotonic is like, okay, good. Now we can really start strengthening. If the doctor orders concentric versus or eccentric strengthening, that means the doctor is concerned about the length of the muscle. So a concentric contraction is a shortening contraction. The muscle is contracting and shortening. An eccentric contraction is where the muscle is lengthening. Okay. You need to be familiar with that because they could give you a scenario on the exam of, describing a movement and saying, is this a concentric or eccentric contraction? Now, I have to tell you, I love, in our textbook, I did this section on concentric, eccentric, isotonic strengthening. Review that, go over it. I have a very simplified way of describing it. Now, the way I describe it in there is for us as OTs and using it in function. When you go to a gym, some of the exercise machines may not fit, but take a look at what I'm saying there. Strengthening can also be completed by hands-on with a therapist. TheraBand, free weights, hand grips, Therapeutic. There's all kinds of different things that we use to strengthen muscles. And strengthening is best addressed during performance of tasks. So there is nothing like having a person do a functional task. And I have worked with shoulders for many, many, many years. And, I would give a person after a rotator cuff repair, once they were okayed by the doctor, we'd start with isometric, then we were okay to move on to isotonic. And we give them some free weights and you'd see the shoulder hiking, like they were compensating. You don't want that to happen. You want them to use their muscles. You have to say, should I put this person supine? So watch for questions on the exam about, is it best if they're compensating too much? Maybe you need to work with that person strengthening their shoulder supine and not against gravity, okay? And the other thing is, I would use functional activities, and I had people would get so involved in the activity, they weren't thinking of compensating and that they were lifting a weight, and you wouldn't see that kind of substitution. So using activity is so important in strengthening. Okay, so what I'm going to do, hold on one second here.